Dr. Ashwath D as a moderator for today's Pedia Connect webinar. I extend my warm welcome to all delegates. It is my pleasure to introduce Dr. Ashwath D, who is today with us as a moderator. Dr. Ashwath D is pediatric specialist from KMCH Hospital, Main Center, Coimbatore to moderate the session. Dr. Ashwath has around 26 years of rich experience with an inclination towards academic learning and teaching initiatives. He has around 11 years experience of teaching and guiding DNB students. He has been actively participating as a speaker in various scientific fora. Dr. Ashwath is also associated with a lot of parent education activities in schools. Moreover, he is also an active PALS trainer. Welcome, Dr. Ashwath. And with this, I hand over the entire session to you, sir.
Good evening, dear friends. It gives me great pleasure to be part and parcel of this excellent academic initiative from Samarth. And it is the pleasure is doubly mine for introducing a very valued and respected and very dear friend, Dr. Kalyanasundaram. Without taking too much of time, Dr. Kalyanasundaram did his undergraduate education from Kilpauk Medical College, Chennai, and then went on to do his MD General Medicine at the Mecca of Medicine in South India, that's Madras Medical College. He subsequently did his fellowship in cardiology at Hyderabad and has been active in the field of pediatric cardiology for the past 20 years. So if you can do a simple mathematics, our heart rate, assuming that it is beating at 70 beats per minute, in a day it beats about 1,800 times. That is exactly the experience of Dr. Kalyanasundaram in pediatric cardiology. He has done close to 90,000 echocardiograms. He has done nearly 4,000 to 5,000 procedures in the form of ASD, VSD closures, and PDA closures. He has been at the forefront of innovating, especially VSD with devices where others have become, have advised surgical closures. Sir has been adventurous enough to go ahead and offer them a non-surgical alternative with great success. He is also a very, very sought after pediatric cardiologist, an esteemed member of the pediatric fraternity, a person to whom we can refer our patients with a lot of confidence. And he's a very kind and compassionate human being, as I know him personally. And he's a much celebrated speaker at various national and international fora. So with these few words, I will now sign off. And at the end of the talk, which will take probably 40 to 50 minutes, you can keep your queries coming because heart failure is such a common and confusing clinical problem that you could keep your questions coming, with the Samarth team will forward to me. So we'll have a lively interaction at the end of the deliberation. Thank you. I'll now sign off and leave Dr. Kalyanasundaram to go ahead with this presentation.
Thank you very much, Dr. Ashwath, for the kind word. So thanks a lot. Yeah, I thank the
yes, sir, you can share your screen.
Yes, actually, so wonderful things they have done is none of the company have done is they have made assay. There is FUSI made. So far it was only tablet form. We used to give only a tablet form and mix it with the small it's difficult. So I made it this simple form of liquid form. Second one is same thing is digoxin. Digoxin was also available only in the tablet form. This is the only company made the syrup form. So definitely is very, very useful for us. I think I should thank them for making this product. Okay, definitely from my heart. Not because they arranged this meeting, but I always thank them whenever their representative meet me. They said because of your company, I think my job is easy. Otherwise, I had to make the tablet and make it in mix it water and give all those things. Because the problem is small children giving mixing it and giving the tablet form is difficult. So wonderful things they are doing it. So anyway, I had to thank them for their work. Okay. So with that, we'll move on to the As Dr. Ashwath said, it is a management of heart failure in children is really a somewhat difficult to one, because it is not like adult where you have the fixed form of management. It's every children it varies their management, and the approach also different, and there are multiple diagnoses for heart failure, not like adult, very few diagnoses are available. So with that, we'll move on. There are many definitions are available. So probably because since it is, we cannot accommodate a few, because definition means we have to tell the few lines. We cannot give a paragraph. So for that, that's why some of the definitions will cover some partial and some of things other parts. So that's why we have different types of definitions. Okay, what are the widely used definition I'm going to tell? So then subsequently move on to the main one. So definition: heart failure is a syndrome defined by the failure of the heart to deliver oxygen at a rate commensurate with the requirements of the metabolizing tissues, despite normal filling pressures, or it does it so at the expense of the increased filling pressure, secondary to an abnormality of the cardiac structure and function. I will explain to you what is that. Actually, you need the explanation for the definition of this one. So there are three factors here. One is failure of the heart to deliver oxygen. What does it mean? So heart is just pump. It has to pump out and deliver oxygen. Of course, oxygen along with the nutrients to the tissues of the body. Okay, so it has to support the requirement amount. It varies. At rest, maybe some this may reduce cardiac output, and the maximum exertion like running or in sports, they need high cardiac output. So we have to adjust accordingly. Okay. So failure of the heart to deliver oxygen means failure to pump out enough blood to reach the metabolism tissues. Second point here is filling pressures. What is meaning filling pressure here? I'll explain to the next with the diagram. So, say, despite normal filling pressure means the cardiac output is maintained with the filling pressure in the normal stage, or it maintains the cardiac output but increased filling pressure. So that I'll explain the next slide. Third is the cardiac structure or function abnormalities. Okay, so that's what we are going to talk about, the various causes of cardiac failure. So look at the picture. So you can see that atria ventricles. You know, the cardiac cycle is broadly divided in two phases. So it is diastolic phase, another one is a systolic phase. So diastolic phase is nothing but the filling period of the ventricles. Systolic period is the emptying period of the ventricles. The filling period of the ventricle looks simple, but it has got there are different mechanisms to fill it. So here, as soon as the emptying is over, there's a systolic phase is over, the heart is filled with less amount of, this ventricle is filled with less amount of blood. Okay, one. So as soon as that is, that means that the pressure itself less compared to the initial state of the systole due to the less volume. Second, once it reaches the maximum contractile stage, it starts relaxing it. So once it relaxes it, then the AV valve, that's called mitral valve and tracheal valve, start opening it because of the pressure difference between the atria and the ventricle. For example, once pressure of right ventricle is reduced to the level of less than the atrial pressure, and then both when the AV valves opens and fills the ventricle. So it goes up to the level where the pressure is raised or filled, then contractile, that is contractile starts, then AV valves closes. Okay, so this phase has got two. One is early phase, that is early filling phase, late filling phase. That's called early diastolic phase and late diastolic phase. The early filling phase, it depends on the mostly of the pressure difference. There is no any contraction in the atria. Okay, it's just ventricle relaxes and there is a pressure difference between these two chambers. There's the atria and the ventricle that start filling. The later part of the diastole, where the pressure is equal, then atria comes into act, that is contracts. contracted phase. So it contracts, atria contracts and fills the remaining amount of blood which is needed to, it has to be ejected out. Okay, these are two phases. Here, where the abnormality comes, so some of the heart where, as mentioned there, filling pressure is normal and the filling is abnormal. So filling is abnormal means here some of the situation, for example, restricted cardiomyopathy, where the ventricle doesn't relax as expected. So it is a restricted. The relax is very limited. Elasticity is less. It is called compliance is less. Because of that, filling is not filled in the early phase. So because of this early phase is not how it's filled, then again, so the early phase is less instead of normal amount of filling, let's say lesser amount of filling will be in the early phase, but atria comes and act early and contract, pushes more. That means, so it is maintained by the atrial kick, atrial contraction, so the cardiac output will maintain. Okay, so if this is it keeps continuous, early phase of restricted cardiac probably it maintains, later phase probably it's so stiff it cannot be able to fill it, and resulting in low cardiac output. Heart, there is a heart failure. Okay. So this is called the earlier phase. I mentioned that definition. Cardiac output is maintained so with increased filling pressure. That means when the increased filling pressure increase, automatically there are some other changes. So, for example, atrial pressure is increased. You know, the tube connected to them or the SVC and IVC, their pressure also increased, so engorged. So as the IVC is engorged, probably the liver engorgement and the gastro engorgement, all these heart failure symptoms will start. Same thing, left side, pulmonary, left atrial pressure goes up, then there is naturally a pulmonary venous pressure goes up, and then pulmonary congestion occurs. So this is called diastolic heart failure. Okay, this is the color. It includes myocardial problem and also pericardial problem. Those things will behave like diastolic dysfunction and cardiac failure. Okay, so that's what that meaning. Of course, structural abnormality, maybe there's a defect, stenosis, regurgitation, all those things we are going to talk. And second thing is maybe a myocardium itself is depressed some stage that we are going to talk on that. So the another simple form of definition is heart failure refers to a clinical state of systemic and pulmonary congestion resulting from inability of the heart to pump as much as blood as required for the adequate metabolism of the body. So this is also same, but the some of the criteria is not included in this one. We'll move on. So what is the relationship between these two? It is both are pumps. Motor pumps. Okay, so one is made up of metal, another is made up of tissue, biology. So what is that? One is the metal motor, that is motor made up of metal, and another one is motor pump made up of biological tissues. Okay, so it has got common things. It is a heart center. Then it has got inlet pipe for the motor, and the same thing for the heart. There is IVC main inlet, and of course outlet is aorta here. That goes this is the aortic pipe to the supply the forms. Okay. So what you need another one, run these two. To run the motor, what is the requirement? It is a electricity. Okay, it has got the wire and connection like that. Same thing, heart also needs electricity to pump. Otherwise, they will not contract. That's called ECA node, sinoatrial node, which is situated between the junction of the right atrium and the SVC. So this is the generator. It's the electricity generator. So it generates electricity roughly about 60 to 100 in the normal situation. It makes the heart to contract. So electricity also one of the bottom one here to any abnormality in electricity production or conduction also resulting in heart failure. So next, so the comparison. Here, so not enough water reaching the motor pump. That's like valve stenosis, restricted cardiomyopathy or congested cardiomyopathy. that will have the cardiac failure. So weak motor, myocardial dysfunction. So motor there is weak, probably cannot pump out the water. Similarly here, myocardium is weak, probably cannot pump out. Pilferage, so leaking out. So there is a leak after pumping. There's a lot of leak before reaching the farm. Definitely, there won't be sufficient enough water reaches. Same here also. There's enough blood is coming into the heart, but there is circulating within the heart or outside the heart without going out. I mean, without reaching the enough blood to the periphery. The same thing. So just have a look. This is what the comparison of the similarity. So look at that. This is some leak here. Enough water will not reach the form. Similarity here is the communication between the two upper chamber like ASD. Same thing, communication between the two lower chambers like BSD. Two communication between the two outlet, that is great arteries, that is pulmonary artery, aorta, then it's like papilla. There's so many other conditions they're resulting in heart failure because of there's not enough blood is reaching the periphery. So this is simple. So if the enough blood is reaching, we'll see the greenery. So well irrigated form. If it's inadequate, probably you can see the less greenery. So it is a poorly irrigated form. Similarly, the heart is good. There's no any defects. Probably you can see the well baby. And of course, there is a defect like a VSG here. The child will be like this. So we'll move on to next button. That is a heart failure in children. How they classify? There are various classification. It is for clinical usage classification. Heart failure with normal myocardium. Heart failure with abnormal myocardium. Heart failure due to arrhythmias, heart failure due to pericardial disease, and combinations of these things. What are the conditions under heart failure with the normal myocardium? There are volume overload conditions like left to right shunts like VSG, PDA, AP, so many other conditions are there. And pressure overload like valvular stenosis, severe aortic stenosis, severe mitral stenosis. Combinations, that is valve stenosis, valve plus shunt lesions, stenosis, regurgitation, or shunt lesions like ASD, VSD. Of course, with myocardial involvement, maybe myocarditis, post-myocarditis, cardiomyopathies, coronary artery abnormalities, Kawasaki disease, or coronary artery stenosis, coronary AV fistula, so many coronary abnormalities, arrhythmias, bradycardia, tachycardia, all those you can cause. So coming to the clinical usage of how you approach the clinically in heart failure, we can approach heart failure clinically in the using the age wise. Okay, the reason is it will be useful for you management also because of the various age, the presentation also varies, and also the diagnosis also will vary. Coming to heart failure in fetus. Heart failure in neonates and heart failure beyond neonate. Because heart failure neonate may be again further into three groups. First day of life, heart failure, first day, week of the life, and heart failure the second week of life. We'll discuss a few things about the heart failure in the fetus. Disorders which cause heart failure in the fetus, like tachycardia, SVT, supraventricular tachycardia, ventricular tachycardias, severe bradycardia, like complete heart block, anemia, regurgitation like Epstein anomaly, mitral regurgitation like AV septal defect, myocarditis. These things can cause heart failure in fetus. How do you identify it? The form of hypertrophy fetalis. You can see the ascites, pleural effusion, pericardial effusion, and ALCAPA. This can be diagnosed using fetal echocardiogram. So treatment, because if it is tachycardia induced cardiomyopathy, heart failure, probably you can use the digoxin, procardiac quinidine, amidone for the mother. So it will cross the placenta and control the arrhythmias. And steroid, say routinely, one of the cause of complete heart block is the systemic lupus erythematosus for the mother. So you know the antibody crosses placenta and damages the AV node. So for that, routinely we used to give steroids by the mother, prevent the steroid-induced inflammation and AV block. But in the latest, recently they published JACC, journal JACC, It's called hydroxychloroquine, which is now this COVID era is being used. They have published data. If you give a 400 milligram per day to the mother, and we can reduce umbilical block in SLE mothers about 50%. So anyhow, this is what recently published. Probably you have to see that how it's going to be useful clinically. Coming to heart failure in neonates, it's difficult to diagnose and also difficult to distinguish from the pulmonary disease and sepsis. So overall practice in neonates, probably you can understand sometimes they find difficulties, whether excitation, dyspnea, all those things due to lung problem or sepsis or due to heart problem. So there's a problem always exists whenever you're dealing a child, a neonate child with heart failure. Coming to the heart failure, the first day of life, most structural defects do not cause congested heart failure. Please note down. So first day of life, if there is any heart failure symptoms, probably don't think of less likely to be a congested heart failure. Less, we cannot say complete. It's less likely. So myocardial dysfunction is secondary to asphyxia, hypoglycemia, hypocalcemia, sepsis. Of course, mitral or tricuspid secondary to hypoxia, Epstein anomaly are the main things that we used to see. Okay, so these are the causes. So if you see the heart failure in children in the first day of life, probably these are the causes you should always think of. But congested heart failure will not severe heart failure in the first day. You can see in the next slide how, why. So if there is a failure in the first week of life, please look for the serious cardiac disorders. Needs sense of urgency, possibly due to closure of the ductus arteries also. So both that's why you have to always check the both upper limb and lower limb pulses to find out some of the heart diseases. Of course, right to left and ductal shunting can be diagnosed using that pulse oximetry and pulse BP and also pulse. If there is a right to left hand, it's using the pulse oximeter and saturation and also your pulse. Probably you think of severe pulmonary hypertension, not necessarily any abnormal structure abnormality, probably a severe pulmonary hypertension shunting to the right duct and also coarctation of aorta, then interruption of aortic arch. Okay, these are the three main conditions we are supposed to think of. There is a right left as being noticed using the your saturation, the pulse and the blood pressure. Heart failure in the first week of life, PDA does not cause heart failure usually in mature babies, but PDA may cause heart failure in premature babies due to poor myocardial reserve. So among the commonest shunt, the AHD, PDA is the notorious in causing severe heart failure in the first week of life, probably especially in the newborn of premature babies, because of they have poor myocardial reserve, unlike mature babies. So AHD, BHD does not cause heart failure because it needs some more time pulmonary arrest to come down. We'll see that in the next slide. Look for the associated condition. If the AHD, BHD are causing heart failure, probably you are missing some other thing. Okay, it looks like total anomalous pulmonary connection with the AHD. So I used to see like this referral with the AHD heart failure. Then definitely we don't believe. I used to think something's wrong. So the first week of life, child is sick. Only AHD, something we are missing. So that's why always go and look at some of the possible potential causes of the treatable causes of heart failure in the first week. That is a total anomalous pulmonary connections, coarctation of aorta with the VSD. Okay. Some say we used to see that also. So my small VSD, they may miss the coarctation of aorta. This chance of missing also is newborn unless you use a different maneuver to find out the coarctation of aorta. So heart failure in the first week of life, renal insufficiency due to enzyme deficiency, neonatal thyroid sclerosis. That's also to be keep in mind. So they are all rare causes. Still, you have to keep in mind. Heart failure beyond second week of life. Yes, here comes to normal the shunts, that is frequently diagnosed shunt lesions, that is AHD, ASD, patent ductus arteriosus, anomalous arch of left coronary artery from the pulmonary artery. It's called ALCAPA commonly. Why second week? The reason is reduced pulmonary resistance. That is, it takes 4 to 6 weeks to pulmonary vessel to come down. So unless pulmonary vessel comes down, the pulmonary artery pressure will not come down. That RV, which is connected to the pulmonary artery, also will be higher pressure. So the shunt will be minimal. There won't be any significant shunt to produce heart failure. That is the reason it takes time to produce a symptom. So because of the because of pulmonary vessel, high pulmonary vessel doesn't cause heart failure in this up to at least the second week of life. Heart failure, suppose some of the, even though the large VSD AGPD is still there, and even reaches for 6th week also, child may not be still symptomatic. In that case, there may be some hypoxic lung disease. That means the lung is not wet due to the some other reason. So there will be any symptoms of heart failure because hypoxic lung disease with high altitude, the pressures will be high. Follow-up of how do you follow up? See, these are some of the things you did not go into aggressively close it. So like you have to follow up these children, like left right shunt children. Heart failure due to left right shunt like ASD, VSD, we have to do close medical follow-up. Why? Because some of them may get close spontaneously. Okay, close spontaneously. So symptoms improve. Sometimes symptoms may improve, but something going wrong there. What are they? So development of pulmonary hypertension. Okay, that's why you mentioned close medical follow-up. It's a large shunt. So they may develop slowly pulmonary hypertension. They develop tension, the pulmonary artery pressure may come down or may go up immediately, or sometimes they may not come down at all. Pulmonary hypertension. They may have percent pulmonary hypertension extending beyond the normal period. Of course, they may develop in the VST situation. They may develop pulmonary stenosis called right ventricular outflow tract obstruction. Their muscle bundle can develop because of the VST. Especially, it is not due to large VSTs. It's usually due to the small VSDs or moderate size VSDs. These VSDs develop pulmonary stenosis. So we have to find out. And also may they develop complications like aortic regurgitation. So we have to be very careful. So coming to ALCAPA, anomalous ulceration left coronary artery from pulmonary heart failure due to ALCAPA, presentation will be like excessive crying with sweating, angina, myocardial infarction, of course. It's like almost like these children almost behave like adult patient presented with heart attack. So because it's also heart attack here because there's won't be any sufficient amount of blood reaching the myocardium, resulting in ischemia and infarction sometimes. So ECG, if you take an ECG, you can see the Q waves in the AL and AVL in the lateral leads, and of course there will be LVH also may be there. So most of them we used to see most of these ALCAPAs are missed and misdiagnosed as a dilated cardiomyopathy. So we have to be very careful whenever a child is presented with heart failure symptoms and the myocardium, the echo is reported outside dilated cardiomyopathy. Probably we have to review again there is any missing of ALCAPA, because the reason is ALCAPA is the one, it's a curable condition. So dilated cardiomyopathy may not be curable, but ALCAPA is the one which is curable. So you have to give importance to that, identifying it. Heart failure beyond infancy, unusual in patients congenital heart disease. The reason is they all develop around 6 weeks of life. So first time developing heart failure beyond infancy, probably you have to think of different etiology for the heart failure. So you present maybe still maybe VSD, you think of associated complicating factors like valvular leakage, may develop valvular leakage. For example, VSD, sometimes they may complicate with the aortic regurgitation because of the VSD. Some locations, for example, 3 members VSD, subpulmonary VSD. These VSDs are notorious developing valvular regurgitations. That's why those children we have to follow. We don't just leave it. We used to see like this problem. They go to some doctor and they do echo and they go to the physician. They then even the doctor who did echo say that you'll get close go. So the same thing would be conveyed to the family physician. He also said that the doctor said they'll get closed. So they'll after some day they come to us a few years later with the complications of VSD and the regurgitation, aortic regurgitation. Why still? I mean, you can think of that. Even this is correctable. No, why? What is that big deal? That yes, if the VSD alone is once closed, lifelong, the child doesn't need any treatment. There is associated valve regurgitation, probably if it's repairable, well and good. If it's not repairable, we have to go and replace the valve. That is going to be the problem. That means replacement of the valve is going to be introducing new disease. So it always be very careful. So another thing is they may develop infective endocarditis. So that is another complicating factor if the existing heart disease, which may not giving any problem, like VSD or PDA, they may be associated with infective endocarditis with fever and also heart failure. Myocarditis, anemia, maybe is present along with this. Other heart disease, like for example, surgery done, betation, the shunt is large, probably they can produce a heart failure. Uncommonly worsening of itis stenosis, pulmonary stenosis. Earlier it was a mild or moderate itis stenosis or pulmonary stenosis. Sometimes they progress to severe itis stenosis, severe pulmonary stenosis. They may present with a heart failure. Of course, beyond this, apart from this, if you have if you see a child first time present with heart failure, you think of acquired heart disease. What are the acquired heart disease? Yes, rheumatic heart disease still prevalent in our country. So cardiomyopathy is another closest cause of heart failure in children, like dilated cardiomyopathy. Of course, that's the commonest one. Hypertrophic cardiomyopathy is of course uncommon. Of course, restricted cardiomyopathy is also uncommon. Kawasaki disease, yes, it is a potential cause of heart failure because coronary heart disease involvement, coronary heart stenosis, coronary aneurysm, thrombus formation, acute can develop, like myocardial infarction, myocardial ischemia, like any other adult patient getting heart attack. So pericardial disease, yes, as mentioned, large pericardial effusion, tamponade, they can present heart failure, or chronic heart disease like constrict pericarditis, they can produce the heart failure. Okay. Arrhythmias, yes, tachyarrhythmias, bradyarrhythmias, both can cause heart failure. Mechanism of heart failure is myocardial failure, normal heart with the load that exceeds its capacity to handle. Of course, impaired ventricular filling. These are the mechanisms. So myocardial failure is not contract. So normal myocardial, but it's volume over, like excess shunt lesions. Impaired ventricular filling, like restrictive physiology or constrictive physiology, and they can have a heart failure. Coming to pathophysiology heart failure, a combination of relatively low cardiac output, compensatory responses to increase it. So this is the one. We'll go on detailed discussion on this one. Coming to physiological response to the heart failure. Once the heart failure occurs, what's happening? There is low perfusion to the kidney, resulting in release of renin, which acts on angiotensinogen, which is released from the liver, converting it into angiotensin 1. Which angiotensin 1 is converted into angiotensin 2 by ACE, the angiotensin converting enzyme, which stimulates the kidney, releasing aldosterone, and also directly act on the kidney, resulting in retention of sodium and water. Okay, this is the one. So resulting in volume overload. Second, because of hypoperfusion, there's a carotid and a left atrial receptor get stimulated, resulting in sympathetic output, excess sympathetic output, which produces tachycardia and vasoconstriction. So both contribute to the heart failure. Okay, we'll see the mechanism later on. So this I just mentioned. So angiotensin released from the liver is broken down into angiotensin by the renin. Angiotensin 1 is converted into angiotensin by the ACE angiotensin converting enzyme. Then angiotensin 2 go and act on the adrenal, release the aldosterone. So this aldosterone and along with the angiotensin also both can act on the kidney, retain the water, sodium and water. Okay. So effects of angiotensin 2, so it produces vasoconstriction directly and also produces myocardial hypertrophy and fibrosis. Long-term consequences of heart failure. Of course, aldosterone release, which I mentioned, resulting in water retention. Activation of noradrenaline endothelin also does this angiotensin 2. Of course, what does aldosterone does? Pulmonary edema and of course pulmonary and peripheral edema because of water retention. It also does myocardial cell loss via apoptosis. So it is also produce aldosterone. So myocardial fibrosis also creates increase after load. All those things are the excessive aldosterone activity. Increase sympathetic what will happen, so increase heart rate and increase blood pressure resulting in myocardial oxygen consumption. So already weak myocardium it increases the more excessive myocardial consumption, resulting in further depression of the myocardial function. Myocardial cell death, continuous chronic activation of sympathetic activity, resulting in myocardial cell death occurs, resulting in muscle loss, myocardial muscle loss. Down regulation between stress in the heart, which is the one which is stimulates heart myocardial contractility. So all those things can occur with the continued sympathetic overactivity. So other effects like vasopressin, water retention, the vasoconstrictor, cytokine A apoptosis. This apoptosis means problem cell deaths. Once this is stimulated, probably cell will die over the period. So it's a programmed cell death. Of course, endothelium is a vasoconstrictors. All those things, adverse effects on the already burdened myocardium, which cannot handle the, which have to pump out enough blood to the periphery. So, why these secondary activities there after heart failure? Is there in benefit or adverse effect? Yes, there are benefits, but there are adverse effects simultaneously. Yes, fluid retention increases the cardiac output by increasing intravascular volume and end-diastolic volume. It's increase the preload, thereby maintains the blood pressure, perfusion. But this continued effects resulting in pulmonary edema, systemic congestion. Second, vasoconstriction due to various mechanisms which I mentioned earlier. It maintains the vital organ flow. So it is helpful, but it's all useful for a short term. If it continue to be there, probably they can have this elevated, this continue for a long time, they can develop the heart failure and increase the myocardial work, thereby depress the myocardium further. Of course, increased contractility due to sympathic overactivity is useful in this period because it increases the ejection more, whatever the volume left over in the ventricles try to eject out, but also increase the myocardial work, thereby increase oxygen demand and depress myocardium further. So adverse effects of compensating mechanism, the sustained and prolonged compensating mechanism may also result loss of myocardial cells, fibrosis of myocardium. Of course, what are the symptoms they can present with? It can be tachycardia, tachypnea, excessive sweating, excessive crying, feeding difficulties. What do you mean by feeding difficulties? The feed will be very less amount that they take, because taking feed for short period then becomes tachypneic. That means it won't take continuously like normal child. It stops, takes for short period then stops because of the dyspnea. That's equivalent dyspnea in adult. Taking feed for short period and fall asleep. That's called fatigue. So all those can happen because prolonged feeding. So normal feeding is between 10 to 20 minutes. This child they take about 2 to 3 minutes or 5 minutes maximum. They stop taking. So what's happening? Then I get up and cry because of this hungry, because of this stomach is not full. At the same time, the child is not able to take the full stomach because of the dyspnea, fatigue, all those things. Of course, diminished urine output. Normally, it is a late stage. So the diminished output is there. Probably child is very, very sick. So it's unlike adult. In this diminished output is a very bad sign of heart failure. Signs of heart failure, yes. Failure to thrive, weight gain is more affected than the height and head circumferences. Of course, they can be pale, ashen pale, and mild cyanotic. You can see, look at the significantly cyanotic child, heart failure child. Flaring up in alienation. And of course, peripheral edema will be less frequent compared to other adult patients. Tachypnea will be there normally 50 to 100 per minute. Of course, sleeping child, respiratory rate is more than 60, probably always strongly suspect heart failure. Tachycardia about 160, 180 you should always suspect. You should strongly suspect heart failure. Of course, anything rate more than 20, you think of tachycardia like LCT. Of course, intercostal indrag is a commonly seen heart failure in children. You can see that whenever you see the child, suspect child with heart failure, probably you look at the intercostal region, you can almost give the diagnosis. Pulses alternance, of course, strong and weak pulse, especially children and severe heart failure. Pulses part access, and so you can see that is a decreased pulse volume and the BP with inspiration. JVBC is less useful in infant children because active breathing and secondary respiratory muscles are used actively, but difficult to assess it. It's difficult to them to cooperate for that. So gallop rhythm, of course, some of the physicians they pick up gallop rhythm and they suspect strongly heart failure. Other system, they give any signs of heart failure? Yes. These is the commonest one. Of course, crackles, crepitations are uncommon in normal heart failure children without any complications like pneumonia and severe heart failure situation. Only you can get grunting. Yes, the most common signs we all see in heart failure. Emphysema, especially left upper lobe and lower lobe, think of heart failure. The reason is, of course, lung collapse also left lower lobe. The reason is due to obstruction of the left main bronchus by enlarged left atrium and pulmonary artery. Of course, fluid effusion also uncommon in heart failure patients. It's there, probably severe. Another thing is abdomen. Of course, heart failure patient still you suspect. Just put a finger on the abdomen. See that hepatomegaly is there. Almost you're thinking that you are based on your clinical features plus hepatomegaly, and it almost give you the clue that a child is having heart failure. And you can confirm by giving the diuretics. It regresses quickly, so it means it is you are dealing with the heart failure patient. Okay, so ascites also you can see some of the severe heart failure patients. Of course, moderate heart failure may not be very sick like what previously mentioned. So less than they say less than 3 ounces per feet, greater than times more than 40 minutes per feet, abnormal respiratory pattern, resting respiratory rate greater than 60 per minute, with diastolic filling sound, all of course moderate hepatomegaly suggestive of moderate heart failure. I mean severe heart failure, this heart rate is more than 170 per minute, decreased perfusion, that is CFT is encased. Severe hepatomegaly, there's more than 3 centimeter, pulses are alternates and pulsar products suggestive of severe heart failure. Another important thing you have to always sense it, impending shock. Whether the child is going to have an impending shock, plus then you have to pick up some signs. The cold extremities, that means you see the child is present with cold extremities, this is danger. Probably you have to shift the patient to ICU immediately. Of course, low blood pressure. Skin mottling, yes, skin mottling is very common in small children. We used to see skin mottling. Looking at of course, there are other causes for skin mottling like infection, all those things. But one of the cause of skin mottling is the low cardiac output due to heart failure. Heart failure scores, there are score system is there. If you especially for infants, you can use it. So breathing difficulties, interrupted feeds, vomiting, sweating, poor activity, irritability, edema. Each carries 2 points and 1. If it is severe, probably 2 carries, and of course less, probably 1, none means 0. So more than 7, probably you think of the severe heart failure. Chronic heart failure, yes, poor feeding, recurrent respiratory infection, increased metabolic requirements, that is failure to thrive. Weight gain is more afraid than the height. Because you can see the children all be very tall, and they say, but it will be very thin builds, because the weight is always affected more. So head circumference will be also relatively normal compared to weight. Cardiomegaly, yes, chest X-ray more than 60% newborn is a criteria for the cardiomegaly. Of course, for the older children, 50%, more than 50% is taken as for the heart failure. I mean cardiomegaly. Absence of cardiomegaly in inspected field, that is diaphragm near 10th posteriorly, exclude heart failure except obstructed TAPVC. Expected film, yes, misinterpreted, so always take a inspected film. Pericardial effusion is rare. Of course, you can see the X-ray, exclude thymnomegaly. Because most often we used to see children referred with X-ray saying that heart is enlarged, and most of them, which is by echo-wise, we can identify it's thymnomegaly. We used to send back the letters, the thymnomegaly, not due to any other reason. So, if you have a thymnomegaly, if you have chest X-ray with cardiomegaly, probably there's no other symptoms you think of as a thymnomegaly. Okay. So some of the X-ray I'm just going to show you. So this is the X-ray of normal. See, you have to see what are the locations of these structures, so that the abdomen also can be expressed. The right heart border, you can say right atrium is in the lower portion of the heart is right heart border. This IVC comes here. Then right descending pulmonary artery. The area below this is right pulmonary artery, and of course at the level of the hilum it's a right pulmonary artery. HVC, of course, this location is this there, and ascending arch of aorta, ductus arteriosus, pulmonary artery main. LPA normally we don't see because it goes behind the heart. So difficult to see because in the levocardia, left pulmonary artery goes behind the heart. The abnormality of left pulmonary artery is difficult to see. So left atrium and the left ventricle comes in the large. So this is the one. So coming to right, how do you identify echo-wise, X-ray wise right ventricular hypertrophy? Yes. Look at that apex, subturned the apex above the diaphragm, above the diaphragm. Of course, you can confirm it if you take lateral view and the retro space to heart will be obliterated. So suggestive of right ventricular hypertrophy. Coming to left ventricular hypertrophy, look at that that apex is merged with the diaphragm. Of course, reverse of our right ventricular enlargement, apex. Of course, inferior displaced. Mitral stenosis, yes, I can see the bulge in the left upper side, left atrial border. The other signs of pulmonary venous hypertension is there. Prominent upper lobe veins, of course, Kelly B lines, the horizontal lines in the horizontal lines is called Kelly B lines. Of course, same in the center, near the hilum, it's called Kelly A lines. Swing appearance of severe heart failures. It's sparing of the outer part of the lung and more on the hilum region, extreme stage of heart failure. So alveolar edema, hazy shadow in the both lungs, you can look at that. This is called alveolar edema. Mitral regurgitation or severe mitral stenosis, you can see the left atrial enlargement, double outlet contour. I don't know whether you can appreciate they are not here. The double outlet contour, such as left atrial enlargement, apex displaced upward, and of course reverse of. Because of the right atrium, severe pulmonary hypertension, there will be right ventricular enlargement and maybe displaced the left ventricle will be displaced posteriorly, and RV occupies the apex. So ASD, yes, right atrial enlargement, upward displacement of the apex with the RV occupying the apex, prominent pulmonary artery. So one next is the BSD, yes, prominent PS. Left atrial bulge, left atrial enlargement, was downward displacement of the apex, suggestion of left atrial enlargement. Okay, so this is the pulmonary plethora you can see here. Coming to the so PDA, yes, pride is a prominent of PDA because of PDA inserted into the duct. The duct also prominent, and pulmonary is a prominent. You can see the pulmonary. Okay, coming to supracardiac TAPVC. Especially not the newborn, we cannot see like this. Probably slightly few weeks later, we can see this type of zone. So vertical vein, innominate vein, dilated vein. All this vein joined together forms the upper part of the figure of 8. So lower part of figure of 8 is heart, upper part of is heart is called it, or snowman appearance they call it, or Golland's appearance. All this is the name be given for this type of X-ray. Okay, so look at TAPVC. Yes, infradiaphragmatic TAPVC, look at that. No cardiomegaly, reticular pattern, transferred from hilum, suggestive of TAPVC. Of course, similarly, we can see other two more conditions like any group B streptococcus infection and also hilum membrane disease, HMD. You can see similar pattern. So three conditions. If you see the if you look at the X-ray like this, you think of all these three conditions. If it's rule out all those two, probably we think of obstructive TAPVC. Of course, any obstructive TAPVC like this only, but infradiaphragmatic is always obstructive. That's the reason. So pericardial effusion, yes, cardiomegaly will be there, autumnal appearance, of course, narrow neck. So clear lung because of the perfusion will be less. So other investigation, other than chest X-ray, we can use the echocardiogram to confirm the diagnosis. Because necessary, you can go cardiac catheterization, confirm further diagnosis. So blood investigation. Coming to medical management, of course, most of the conjunctivitis are only a corrective surgery, but of course, before going for corrective surgery or waiting for spontaneous closure, probably you can resort to the management of heart failure. Okay, so treatment of the cause, yes, I mentioned. The management of precipitating events, very important. Control of the congested state. Treatment of the cause like ASD, BSD, do a closure, or valvotomy, IH pulmonary stenosis, or repair the coarctation aorta, stenting or balloon dilatation of coarctation aorta. Second comes the precipitative events. Checklist. Suppose we have the defect is not very severe or not large, then probably you look at these any precipitating factors for like rheumatic activity. There's a valve regurgitation, there's probably any rheumatic activity. And control rheumatic probably, for example, mitral regurgitation is there, but you control rheumatic activity, probably mitral regurgitation will come down, symptoms also come down. Probably you can postpone the exercise later on. Same thing, any fever with valve regurgitation, look at infective endocarditis, intercurrent infections, anemia, electrolyte imbalance also, illustrating the heart failure existing, balanced heart disease become evidence. Going for heart failure probably due to electrolyte imbalances, arrhythmias, pulmonary embolism, drug interactions, drug toxicity or non-compliance, because we are already child is on follow-up and to come back with failure or any other reason, probably whether they have taken more drugs exit dose or they are not taking at all. So you have to verify that also. Both other systems must be looked at there. How to control the congested? Yes, look at this mnemonic patch. Patch is a patch so between the corrective treatment. So preload, look at the correction of preload, afterload, and contractility, heart rate. So correct these things will probably can control the heart failure. So treatment of congested studies aim is reducing pulmonary or systemic congestion by using diuretics, reduce the elevator afterload or adjust the preload like vasodilators, AC inhibitors, increasing the contractility, increase the contractility by inotropes for some specific therapies, for general measures. Coming to diuretics, we have three groups: loop diuretics, thiazides, and potassium sparing diuretics. So under loop diuretics, we see the furosemide, ethacronic acid, bumetanide. Mostly we use children only furosemide because of the toxicity or related things. We don't use ethacronic acid, bumetanide because adult they use, but there also they reduce. They don't give much because of the more side effects than the furosemide. Well, hydrochlorothiazide, chlorothiazide also drugs for long-term usage. You can use it. Spiranolactone, triamterene, amlodipine, there are potassium drugs, and also spironolactone anti drugs you can use for the some of the prolong the prolong the prognostic drugs. You can see later on. So diuretics leaves the pulmonary systemic congestion rapidly. IV form is this is furosemide, 1 milligram per kilogram body weight, rapidly improves the symptom. With chronic usage, 1 to 4 milligram per kilogram body weight of furosemide, 20 to 40 milligram per kilogram body weight chlorothiazide divided doses. You have to monitor when you are giving the body weight, urea, and also serum electrolytes. Potassium supplement is usually not required with less than 2 milligram per kilogram body weight of furosemide. Please note this point, because I used to see potassium chloride syrup and also furosemide syrup along with that. We don't need to give supplement, but children they can, unlike adults, children they can adjust that kidney can adjust the potassium up to 2 milligram per kilogram body weight. Addition of spironolactone advantages are there. You can see the later on 1 milligram per kilogram body weight. Potassium supplementation is if it's necessary, we have to give 1 to 1.5 milliequal per kilogram body weight. Metabolic alkalosis, hypomagnesemia and hyponatremia are the complication of loop diuretics. Okay, so medical management drugs that improves the symptoms are diuretics, inotropes, vasodilators, beta blockers, aldosterone antagonists, and anticoagulants. Drugs that improve the prognosis, AC inhibitors, again beta blockers, spironolactone. Okay, so we'll go in details of these drugs. What are the rationale of treatment? What is the rationale treatment of this one? Because we know the heart failure mechanism. Then go back the same schematic diagram. So heart failure resulting in renin-angiotensin activation, the release of angiotensin 1. So then angiotensin again increase the heart failure. So angiotensin 2 again release of angiotensin again perpetuates the heart failure. Sympathy activation and release of epinephrine or epinephrine again perpetuates the heart failure. Of course, adrenal stimulation again, aldose release again increase the heart failure. Of course, drugs which blocks this area like beta blockers, so it controls the heart failure. Yes, drugs which acts on the angiotensin, that's AC inhibitors blocks these adverse effects of these chemical stimulators. Of course, adenosine receptor and blockers, it's not fully convinced, unlike AC inhibitors. Still, some we can use it. Suppose there is a problem in AC inhibitor, like they can develop cough, all those probably can use ARB, which is less cough. But spironolactone is another drug which is useful, very useful, controlling the diuretics and also control this adverse effects. Coming to beta blockers, rational. Downgrading of beta receptor due to chronic catecholamine stimulation can be corrected. So to be initiated on admission only, because it may worsen. It's severe heart failure, should not start immediately. You control a little bit, then can start beta blockers, because it may worsen sometimes. To be initiated on admission only. Carbaryl is the best drugs which is so far being given. Of course, other drugs also tried, but still Carbaryl is the best drugs. Well tolerated infants with dilated cardiomyopathies, improves functional. Beta blockers, practical tips: start with the low dosage, increase the dose slowly at intervals up to 2 weeks or more. Avoid in patients with broad bronchospasm, advanced heart block without pacemaker. Improvement symptomatically. Of course, objectively may be slow, but it is a long term. It's very useful. Avoid abrupt withdrawal. Benefits of beta blocker: reduce heart rate, prevents myocardium from catecholamine toxicity, improves beta adrenergic signaling, thereby conductivity will be improved. Anti-apoptosis, that is cell death is prevented. Renin-angiotensin inhibition, thereby effects of bad effects of renin-angiotensin activation is prevented. Of course, improves the quality of life. Increase the survival. Very important. One of the drugs which increases survival is beta blocker. AC inhibitors, yes, prevent the myocardial hypertrophy, myocardial fibrosis, reduce the afterload, inhibits the aldosterone secretion, and thereby increase the sodium retention, reduce the coagulation tendency, reduce the fibrin level, reduce the plasminogen activity inhibitor 1. So thereby coagulation also prevented. Prolongs the life of congested heart failure, improve the quality of life, useful in congested heart failure with hypertension, mitral regurgitation, aortic regurgitations, left right shunts. Of course, precautions, against severe hypertension, volume depreciation, because whenever there's already given a large amount of Lasix or something which is already volume depleted, if you start using, certainly BP drops, then go into renal dysfunction, renal anuria. So be very careful. So test dose 1/4 of the usual dose should be started. Then everything's okay, probably can go out, and also check for the creatinine. So it should not be given bilateral in artery stenosis. Cough is a common problem. There, probably can reduce, stop it, and again restart later on. If it continues to be there, probably can go for ARB. Captopril is used in dose, of course, nowadays not available, only enalapril we are going. So enalapril is being given 0.1 to 2.5 milligram by kilogram body weight per day. Angiotensin 2 receptors, of course, this usefulness not yet mentioned. Probably there is a contraindication for use of, side effects due to AC inhibitors. Probably can use it. Spironolactone benefits: potassium sparing diet as an adjuvant therapy with the loop diuretics, prevents myocardial fibrosis and death. Sometimes they can have refractory heart failure. So you have to think of, you look at for whether this child is taking the adequate drugs which is prescribed. Otherwise, you have to do a combination of diuretics. So IV, then stop oral, give IV, then dopamine renal vasodilating dose. Because sometimes perfusion not there, that itself may be aggravating the problem. Then you have to give the dopamine, the renal perfusion dose. That is just renal artery dilatation, not for the hypertension dosage. This more than 5 micrograms per kilogram will go into a hypertensive dose. Be given 2 to 3 micrograms per kilogram per plate. Of course, inotropes in the sick children are very, very useful. Myocardial contractility, of course, increase the heart rate, increase SVR. So dopamine is the ideal drug. Dopamine, if there's a BP slow, probably combination can be started. If you want one drug, probably you start dopamine rather than dopamine, because it may increase the SVR, PVR, and higher heart rate. Of course, less tachycardia compared to dopamine. Oral inotropes says digoxin, controversy in patients with left right shunt, because normally I don't give a digoxin, but no use. The reason is digoxin useful only if there is myocardial dysfunction there. the ejection does not have any role in normal myocardium. So that is why you don't need, because in the left atrial normal myocardium does not have any dysfunction. So it is not useful. It need not give. Second thing, it may be a controversy. It is maybe it may increase the heart failure. The reason is, suppose you imagine the ejection works and it may conduct the, for example, VSD, increase the conduct of ventricle, then probably a ventricle LV contracts more because it pushes the blood into the RV and increase the pulmonary flow, thereby increase the heart failure. So no, generally it does not have any role in normal myocardium. Even if it is useful, it contracts myocardium. It does not have. I mean, in a VSD-like situation, it no use. It may be it is adverse by giving it. Okay. So rapid deceleration, normally we don't give it, not necessary also. It is all older days we used to, but we don't give it, but it is done away. You can just start early enough. IV DNB can start. Because oral maintenance dose is 8 to 10 microgram per day with no loading dose of 40 grams. Okay, it should be given divided doses always. So, carnitine deficiency, when there's a L-carnitine deficiency, probably you can supplement. Suppose the patient comes with dilated cardiomyopathy, you don't have any evidence, either post-viral myocarditis or congenital or any things, probably nothing common starting carnitine. So I used to give the carnitine along with the other drugs in case of there is no identifiable cause of heart failure. Coming to vitamin D, role of vitamin D, yes, there are reports saying that hypocalcemia is a cause of heart failure. Yes, hypocalcemia rarely etiology of reversible dilated cardiomyopathy. So that is why hypocalcemia should be included in the different diagnosis of dilated cardiomyopathy. Supplement with vitamin D and calcium, they may improve. Okay. General measures, yes, head elevation, sick child should be head elevated. Judicious use of sedation is very important. You should not give more when the child is very distressed. You're not on ventilation. Don't give sedation because they will suppress the respiratory center. Then go into respiratory arrest. So you should not give a sedation when the child is very sick unless you have any support for the ventilation. So temporarily denying oral intake is very important. We get aspirated. So morphine, if you're giving, you can give morphine small dose. Because still child is sick, probably can go for the mechanical ventilation. Because calories should be maintained, so all health should be corrected. Because oxygen, so oxygen is sometimes WHO the things you can give high oxygen, probably increase the pulmonary vasodilatation. Whenever there is a left atrial heart failure, it may aggress the heart failure. So don't give too much oxygen when there is a left atrial shunt with heart failure because it may aggress the problem. So of course, heart failure, there is a PDA. PDA is useful. This PDA is the cause for the heart failure. Probably it is useful. It consists the PDA, so it is useful. So high oxygen probably is considered PDA. It will be useful. Of course, it is a detrimental for the ductal circulation. PDA should be kept open those conditions. So coming to the conclusion, so heart failure due to left to right hand to manage with the diuretics, off-directors like ACE inhibitors, correction of underlying problem, treatment and prevention is very important. Of course, primary myocardial dysfunction, diuretics, upload direction, ACE inhibitors, ionotropes like dopamine, digoxin, correction of underlying cause, treatment prevention. Of course, some of the supplement known cause like vitamin D deficiency you can give, and of course there's a carnitine deficiency you can give. Thank you. Probably. Thank you. Any questions?
Dr. KS, we have a couple of questions from our participants.
Okay.
Would you want a sip of water because you've been going like the heart without any break? You've been going on and on. Do you want to have a sip of water or something? Are you free to take questions?
It's okay. No problem. I can take it. No problem.
Dr. Amit Upadhyay has asked for treatment options for congestive heart failure secondary to asymmetric septal hypertrophy in the specific situation of infant of diabetic mother.
The IDM child with asymptomatic hypertrophy, yes, they can present in the newborn with heart failure. It's not like, unlike that idiopathic Kochosium, where the dynamic obstruction there probably we need to be very careful diuretics. And here we can give, because any restricted cardiomyopathy or hypertrophic cardiomyopathy, here like IDM child with the asymptomatic hypertrophy, if there is no symptom due to asymptomatic hypertrophy, probably don't need to give anything. Over the few weeks, it gets settled down. You can see repeat echo after a few weeks or a month, probably the septal hypertrophy regress back to normal. So if you feel that significant hypertrophy is still there is a failure, probably we can give diuretics, but should not give high dose, because as I already mentioned at the beginning of my talk, restrictive filling, that is, filling is restricted, then amount of blood reaching the left ventricle is less, than cardiac output will start falling down. So this child is sick due to pulmonary congestion. We can give that dose, off the dose of what we are only giving, less than 0.5 milligram reflectome body weight, and check it and wait for it. But we should not give high dose of diuretics in the presence of hypertrophic cardiomyopathy or like asymptomatic hypertrophic cardiomyopathy in case of IDM.
So the other question that Dr. Amit Upadhyay has also raised a query on is the use of intravenous drugs for the management of congestive heart failure of idiopathic origin in the early infancy. IV drugs for management of congestive cardiac failure, cause not known, in the first 2-3 months of life.
Yes, whenever the child is sick, yes, you have to admit the child and start IV inotropes. The choice of inotropes is normally dobutamine, because milrinone also can be started. Dobutamine is a silent drug, and other drugs also can give, but dobutamine is we used to have very good experience in dobutamine. Just I mentioned before. So not that dopamine is ideal drug, it's a dobutamine, because dopamine has got the tachycardia induced and also can elevate the systemic resistance, and may not be appropriate in the situation where heart is a dysfunction. So dobutamine is an ideal drug. You can start with normally 5 mg per kilogram body weight and continue. You don't need a high dose. Some of these they have start 10 mg, 20 mg. You don't need 5 to maximum 7.5 mg start with. It takes time. You need not. It will not give you immediate result. It takes a few hours, sometimes one day also. Start with 5 to 7.5 mg per kilogram body weight and give. Okay. So second things, of course, diuretics. In the acute setup, give only diuretics, IV diuretics, and that also very low dose start with. Unless if the BP is borderline, you should not give high dose. If the BP is okay, probably can go higher dose with we can relieve the pulmonary congestion. Okay. So second things, other drugs which I mentioned, like AC inhibitors, beta blockers, all other things you should wait. You should not give immediately. And the reason is the child may go on hypotension. Okay. Dobutamine and IV Lasix. Digoxin also you can start along with that. The reason is digoxin not only inotrope, it also controls heart rate. It is useful controlling heart rate, because heart rate beyond certain range, whereas beyond 180, the ventricular filling is impaired. If ventricular filling is impaired, then left ventricle doesn't fill properly, then the cardiac output will start falling down. So digoxin useful controlling heart rate also. So that very useful. Then once settled down, probably can go for other drugs like AC inhibitor, beta blocker. That's what I used to do.
There's a question from Dr. Dinesh Kumar on the dose of carnitine. I think it was mentioned in the talk as 50 to 100 mg per kg. Are we right, sir?
Yes. Yeah, correct. That's correct.
There is another question from Dr. Vikram Kudumula on the role of ivabradine in dilated cardiomyopathy cases in children.
Yes, I don't think there's no study says ivabradine using children heart failure. So I think it's out of question using it.
So there are 2 more questions, but these are related to pulmonary hypertension. That's why I thought I'll wait for questions on congestive heart failure, which is the focus of the discussion today. Dr. Nikhil Mehrotra has asked a question on pulmonary arterial hypertension in one, and available treatment modalities. In a related question, another doctor has asked, sildenafil is not available in a syrup form. How do we overcome this difficulty?
Yeah. Yes, sildenafil is not available in the syrup form, but it is available in the IV form. Okay. So it is available in tablet form. You have to mix it and dilute it and give it if you want. If the child is okay, or if you want sick, you can start IV form also. It's available. Still sick, of course, tertiary care center where there nitric oxide available, you can give nitric oxide. We have our center like nitric oxide we used to give. So nitric oxide also another option. Significantly sick child. Okay. So sildenafil oral form. If you want to give small children, you have to break it and dilute it and give the dose. So no other choice. Or otherwise you have to start IV.
So today is the days of COVID. So every specialty is going to be bombarded with bouncers on COVID. So we want to know what are the specific cardiac manifestations that we as general pediatricians need to look for as manifestations specific or very peculiar to COVID-19 pediatric wise.
Yeah, now only they're slowly coming out. COVID also can cause a myocardial dysfunction, heart failure. I think still we have to wait whether COVID is directly causing or indirect effects of COVID myocardial dysfunction. Like probably maybe any other like viral myocarditis possibilities are there. But I think we have to treat like any other child, but only these take precaution. Yes, if the child is sick, distress, I think nothing harm in doing a COVID test and then continue, because suppose in case child is needed for intubation, or it's going to be a very high risk. Intubated people are intubating is getting more risk, like a lot of anesthesia are getting affected. That is why I think my suggestion is, if you are admitted as a sick child, nothing harm in taking the COVID test and continue. Right? And I don't have the data to say yes, COVID is one of the cause for the myocardial dysfunction.
Dr. Shyam Sarvodaya has raised a very pertinent question. This is the bugbear that all pediatricians face. When a 5-month-old child is brought with a history of something which looks like a bronchiolitis, and when we examine the child, we find no cardiac murmur, but there is disproportionate tachycardia, the lungs are flooded with fluid, there is a hepatomegaly, and the echo is showing decreased myocardial ejection and diminished ejection fraction. How do we differentiate a viral myocarditis from a viral triggered decompensation of a dilated cardiomyopathy? Can we ever make the distinction? Does it have practical implications?
It is difficult to differentiate, because some of the viral myocarditis later on go into viral cardiomyopathy. It's a post-viral myocarditis, this cardiomyopathy we call it. So acute stage also viral myocarditis can have the heart failure. So since we don't have a specific drug to address this myocarditis, some they give immunoglobulin can be given, but it is a questionable usefulness. But I always treat this because bronchiolitis feature, yes, cardiac failure also behave like bronchiolitis feature, as earlier mentioned. So I think we have to treat this child as a heart failure patient, like IV dialysis necessary, dobutamine, IV inotropes, and then treat like that. But if you want to differentiate with this myocarditis or cardiomyopathy, at this juncture is difficult. But there's an entity called post-viral myocarditis cardiomyopathy. Yes, following myocarditis, they can go on dilated cardiomyopathy. Of course, some of them, most of them may come back to normal over the period of treatment.
Sir, almost most of the pediatricians or people who are taking part in this webinar, I'm sure, don't have access to good quality pediatric cardiology services that you are able to provide. So are there any serological markers, would troponin or specific patterns on the ECG help us to make the distinction?
Yes, the troponin will be elevated. Any myocardial damage, they'll be elevated only. We are seeing it is being elevated, though we don't do regularly, since we are diagnosed, as I said. Second thing is, ECG, yes, there will be tachycardia. Sometimes that can be only you can see sinus tachycardia, and of course they can have a TV inversion. Some of them they can have, but it's all non-specific one. We cannot say specifically this is the cause for. One common thing what you always notice is sinus tachycardia.
Can an elevated troponin make a distinction between an ALCAPA and a myocarditis and a dilated cardiomyopathy or a Kawasaki with an atypical manifestation?
Yeah.
No coronary artery aneurysm, but the child is having myocardial dysfunction as the sole manifestation of Kawasaki. Can
any acute myocardial event, probably troponin may go up. So it's acute ALCAPA has become symptomatic now. Myocardial dysfunction probably elevated. Of course, myocarditis can be elevated. Any other which are triggering, which is acute, even probably elevated. After some time, it can come back to normal. But in the during acute period, it's difficult to differentiate all those things, all these etiologies.
Very nice, sir. I don't see any more questions. I think we have answered most of the questions.
Yes, sir.
Kalyanasundaram has been speaking without rest. I just have one more question. Sorry, I missed out Dr. Benedict, sir. Do you have the energy to answer one more question?
Oh, no, yes, please, go ahead.
Right. Dr. Benedict Raj has raised a question on a brief mention of importance of surgically correctable structural heart disease, left to right shunts to rescue children in failure. Surgical correction.
Say left to right shunts correction. You can make it a correction. Under that, you can do with the correction surgical, non-surgical. Okay. So commonest left to right shunts are yes, ASD, BSD, PDA, of course. Other uncommon like AP window. And then we get left right shunts like coronary sinus, coronary AV fistulas. So these are some of the there are some uncommon fistulas are there, but these are the commonly seen we used to do. But all these mentioned left shunts can be corrected both surgically and also non-surgically using the transcatheter method. For example, ASG you can close with the devices and also send surgery. What are the cases which you send for surgery? Yes, ostium secundum type of ASG, which is the commonest around 70%. And that about 90% of the ASGs can be closed with the device. Another 10% probably we cannot close because the reason is that rims may not be there adequate to close it. Of course, ostium primum ASD, venous ASD also usually going for surgery. But now sinus venous ASD also can be corrected with the catheter method. That is, we can use the stent. There's a covered stent which close both the ASD and also the abnormally draining pulmonary vein into the left atrium. Both can be corrected. That is now started. And of course, the children are adult are being.
I think we'll have just time for one more question, Dr. Kalyanasundaram, if that's okay with you.
Cost right now. 3 types of BS. Pardon? Yeah, no problem. Okay.
Yeah.
So there are four. You want
No, please complete the answer, sir.
Can I elaborate another defect also? He asked them can be closed with the device closure. Of course, remaining can be another one cannot be closed with the device. That is perimembranous VSD, muscular VSD, subpulmonic VSD, and inlet VSD. Inlet VSD one which you cannot close the device, which needs surgical closure. All other can be closed with VSD. Here also the rim should be adequate and to close the VSD with the device. PDA, of course, most of the PDS can be closed. Even newborn PDS can be closed with the device. Now the devices are available, very, very small, soft, very low profile device. It can be a newborn also. Child is stuck with the ventilator, probably can go and close with the device. So they're available now. Of course, same thing, other things. Remaining, of course, almost all things other than the shunt lesions, cyanotic annuitis, it goes to surgeon.
Okay, probably the very last question. Again, we are coming back to the same old conundrum. Does digoxin have a role in the management of pediatric heart failure in today's world? 2, where do we have the newer drugs like sacubitril and levosimendan and fitting in? Are they medicines for outpatient practice or are they intensive care medications?
Yeah, as a first question, digoxin is a role. Yes, it is there in myocardial dysfunction heart failure. Okay, definitely it's a role. It is there. Yes, it controls. It has got two effects on the heart failure with myocardial dysfunction. That is one. It has contractility. It has a inotrope. And second thing is control the heart rate. Heart rate is very important. I have already mentioned heart rate is beyond certain level. That's more than 160, 170 or 180. Definitely heart rate, cardiac output start falling down. So control the heart rate, the digoxin is very useful. Okay. Second thing, second question is levosimendan. Yes, I used to do few cases unless dopamine is not working. But the role regular usage of levosimendan is not very that much useful. Other drugs is also we don't use for pediatrics, as unlike the adult.
I think we have taken almost all the questions. We have been on air for close to 1 hour and 20 minutes. We, as a team and as on behalf of all the people who tuned in for this Sunday's webinar, I take this opportunity to once again thank Dr. Kalyanasundaram for being so patient and being so exhaustive in his dealing of this topic. And I also take the opportunity to thank Samath Pharmaceuticals for making this meeting possible. I think with that, we come.
Thank you, sir.
Yeah, thank you. Yes,
Dr. Gurunath has joined, sir.
Oh,
so
lovely.
I would like to, yeah, sir. Dr. Gurunath is our medical advisor at Samarth Life Sciences, and he is instrumental in providing us the guidance, sir, on the existing molecules as well as for the launch of new molecules. So welcome, Dr. Gurunath. And if you want to say something on close note.
Yeah, definitely. First of all, really very sorry due to an unfortunate event in my society. I could not attend the webinar from the beginning. I feel I have missed a lot because I have attended sessions last 20 minutes. It was so interactive, so in depth. Congratulations, sir, and thank you so much for such a wonderful session. I would also like to thank Dr. Ashwath for moderating the session in such a nice way. It's